All right, I think we're live. Hi, everyone. Dr. Tom Nabity,
Dr. John Santa Ana,
Michigan Center of Regenerative Medicine. Thanks for joining us tonight. Our topic for tonight is a little bit different from the ones we've done in the past. We thought we'd focus specifically on a condition called diabetic neuropathy. So we're going to talk some advanced treatments that we can offer here specifically for diabetic neuropathy. And then if time allows, we'll dive into some of the other treatments we could do for foot and ankle pain.
Yeah. I think it's a good topic because just because diabetic neuropathy is one of these conditions that afflicts a lot of patients, right? So it's usually somebody who has a history of diabetes, if left uncontrolled or had it for a long time, you do get some sort of neuropathy in your lower extremities, and it's one of these conditions that's really hard to treat.
Yeah, so the patients, when they come in, typically, for those of you who fortunately don't have diabetic neuropathy, it's a burning pain, typical. A lot of times patients say it's like I'm walking on marbles and or sharp nails. Every step hurts, whether you have a shoe on, whether you have socks on, whether you have bare feet. It's just it's an abnormality in the nerve itself where the nerve's misfiring over and over again. So there's no real trauma involved. There's no trigger involved. It just happens all the time.
Yeah. So the idea is that the nerves kind of go haywire as a complication of diabetes. It's just kind of one of these things that happens, and a lot of times the treatments for that are really difficult because everyone talks about controlling the diabetic symptoms, controlling your sugars, but you can have your sugars well controlled, but you can still develop diabetic neuropathy, and painful diabetic neuropathy is what we want to treat.
Yeah, and as both being pain doctors in our specialty backgrounds, it's a tough one. There's medicines available, marginally effective. There's a lot of seizure drugs in particular we'll use, some antidepressants called SNRIs or tricyclics that can be helpful. There's creams that we can use. But there to date really haven't been a lot of procedures we can do. There's no real nerve blocks we can do because it involves so many different nerves, and doing spinal injections doesn't help.
Right.
So it really leaves there's a lot of people out there searching, and there's things like cold laser therapies and acupuncture therapies and other electrical type treatments that in talking with patients seem to have somewhat of a mixed bag, and unfortunately a lot of these patients oftentimes will get eventually led down the path of the opiates and chronic opiate use. With this sort of condition, it's not a real good management, and then you get a lot of the other side effects. So Dr. Santana was proactive and went to a recent seminar and a training seminar on a new therapy using peripheral nerve stimulation. And I'd like to let him have a chance to kind of share with you all what he learned and how we can help those of you who maybe are out there or know someone or loved one out there struggling with this and really looking for alternative options.
Yeah. So the seminar is really good. It was put together by StimWave. They put a really nice conference over at the Cleveland Clinic. And their mission was pretty straightforward, is to be able to bring peripheral neuropathy applications peripheral nerve stimulation applications for a lot of things that's really hard to treat. So we know that peripheral nerve stimulation, similar to spinal cord stimulation, the idea is you're trying to control these nerves from transmitting pain signals by blocking it with a device. So it works well for lumbar radiculopathies, failed backs, shoulder issues, knee issues. These are the more common things that we treat with stimulation. But the diabetic peripheral neuropathy pain, that's a condition where I think this device does really well. It's minimally invasive. Essentially, what we do is it's all done in the office. So we do a trial of it first, like with any stimulation device. The idea is we do the trial in the office. We track where the nerve is with the ultrasound, which is your tibial nerve, and we line that lead, the small, thin piece wider, right in the lead through your skin, right along that path of the nerve, and it will block it whenever you need it. So we start with the trial, same thing. It's the same day procedure. You're in and out of the office. We do it under ultrasound guidance. We put a nice bandage on that. You essentially go home, take it for a test drive, see how it affects your day-to-day activities for about 5 to 7 days. After that, you come back into the office and you tell us how well it worked. Did it help with your pain? And if it did, how significant is it? And it's only if it's a significant pain relief that we'll move forward with the permanent procedure, which is a pretty straightforward procedure where we embed a very thin piece of wire. We're not embedding a battery. We're not embedding a big thing. It's just essentially a wire about this long that goes to the area of the nerve. You're not going to feel it. No one's going to see it. It's not going to wiggle in there. And what it does, it's going to help relieve your pain in there. And the nice thing about it is because we're talking about electrical stimulation, there's no issues with with narcotics or even with these nerve medications where you can have side effects and kind of makes you feel loopy and all that stuff. So it's a really nice treatment. It's one of those things where you actually get to try it before you commit to it. So it's I think it's worthwhile for somebody who has painful diabetic neuropathy who wants to find a better way to address it. I mean, you're not going to lose anything, just try it.
Yeah.
You just have a lot to gain.
Yeah, and I think one of the key things that Dr. Santana touched on was our skills as interventional pain physicians, and in particular our ultrasound skills in guiding needles to very specific areas of your body. By being able to identify the nerve and then very carefully and skillfully place that electrode directly next to the nerve, that's critical in being able to get a good outcome from this. The closer that lead, that electrical lead is to the nerve, the more accurate and the more targeted the electricity is able to be, and the more capable it is of blocking that pain as it's trying to travel up your nerve from your foot to your brain.
Yeah. So I think it's a really nice idea. The funny part is that this technology has been around for a while, but for me, it's like a big realization, like, hey, we could use this device. We have patients that may use it, that may need it, and it would benefit them. I have patients coming in all the time. They know that we specialize in other types of treatments. We specialize in pain management procedures, interventional procedures. But patients also know that we're willing to try out-of-the-box type treatments, especially with stem cells and regenerative medicine and PRP. And I've had patients ask me, hey, does PRP or stem cells work for neuropathy? Unfortunately, it doesn't, or we don't have enough data to tell yes or no it's effective, because it's still one of these things that we don't know for sure. But here's something else I can offer you that I know for sure it's going to help. And it's covered by your insurance. It's not an out-of-pocket expense. It really is a nice benefit for a lot of patients.
Yeah, this is one of the services we offer that most insurances will pick up and will agree to pay for with the right authorization, knowing that we've tried X, Y, and Z. If those things have failed, most of the time they will pick the expense of this up, and our office is capable of assisting in getting that authorization validated and verified before we do the procedure.
Yeah. So if you have a family member or your patient who has painful diabetic neuropathy, or if you have neuropathy, or if you have any other issues with feet pain, leg pain, come and call us. We'll do an evaluation. We'll give you the best options we can. The nice thing about this is, we're not a one-stop shop. We have all kinds of tools that we could give you. We have all different types of tricks in our bag of tools that we can use to address your pain and help you out.
Yep. And Dr. Santana touched on we do get a lot of calls asking, do we have stem cell therapy for neuropathy? Well, I think we do it we pride ourselves in being very forefront with our patients and very upfront about what we have validated treatments for and what are still very experimental treatments. And I think that one falls into the category of very experimental. There are new studies looking at platelet-rich plasma and stem cell therapies for peripheral neuropathy. Where exactly we inject, what concentrations we inject, those are the sorts of things that we want to be able to vet a little bit more before we start offering to the patients. But please know that is something we encourage people to call and ask those questions. We appreciate those questions. It oftentimes stimulates us to go out there and seek additional answers. I mean, that's really what got us into this field to begin with, was patients asking us if stem cell therapy might be good for their knee arthritis and their shoulder problems, and that is what's our impetus for starting this clinic.
Yeah. And then it's one of these nice things about it too, because like when patients come back and give us feedback on what they've seen, what they've tried before, and we see that all the time. Like it's a nice conversation to have when patients are also very into their care, and they're as invested in their care and their health as much as we do, and it becomes a two-way street, and it actually works much better that way.
So I think that's one of the reasons we enjoy our work so much here is our patients are equally as motivated, if not more motivated than we are, to find answers to their problems.
Yeah.
Kind of along those lines, Dr. Santana came to me with an ankle injury not too long ago, and I'll let you go ahead and speak to the therapy we chose and how it's worked for you.
Yeah. So now we'll transition to a more kind of musculoskeletal type foot and ankle pain. For those, I mean, we have different options for that. So just what Dr. Navy was talking about, I've had this chronic ankle injury that I sustained when I was in the military. It's, a lot of running, jumping, hiking, rock, and all that stuff that I actually ended up injuring my ankle pretty bad. I was in the boot for about 6 months. Later finding out that one of my ligaments that on the outside part of my foot, the anterior talofibular ligament, was completely ruptured. So since then, every time I do anything active or if I walk over in uneven ground, I sprain my ankle just like that. I feel like a total klutz every time I walk anywhere. And I can't do anything without a brace. And it's one of these chronic things. I want to remain to be active. I want to be able to do all these sports with my kids and all that stuff, but it's hard to do. And I'm always worried in the back of my head if I'm going to hurt my ankle again and, have to limp around for about a week. Finally, I decided when we kind of learned more about regenerative medicine, I couldn't find anyone else better to do my treatment other than Dr. Navity. So I asked him if he can treat my ankle. This was 3 years ago, 2 years ago, something like that. A really straightforward procedure. In a way, too, it helps me because when I explain to patients how the procedure goes, I can tell them from a first-person perspective, this is how I felt, this is how it was, this is what you're going to feel. And just having that experience, it helps patients understand that I'm not just making this up or read it in a book. Anyway, so we did the procedure. It went really smoothly as expected. And since I had my recovery since then, and it's been great. I haven't had to rely on my brace whenever I do anything active. I haven't sprained my ankle at all, walking around, running around, playing with my kids, walking in even terrain. I'm still more careful when I play sports. When I play basketball or something like that, I still wear my ankle support just because it's one of these things that's more of a mental crutch, but at the same time, it's just, one of those things where I usually would injure my ankle. But the day-to-day activities that I do where I usually worry about twisting my ankle walking in the park, I don't have that worry anymore. And it's just amazing how PRP was able to not just treat my ankle, but fix my life in a way and kept me from being active.
Yeah.
And this is one of the reasons why I'm very passionate about this field, because if it helps my one little injury and actually change my life and how I do things and approach things, and I can offer to other people, then that's something that I think I owe everyone.
Yep. I too have a chronic lower extremity calf issue that I couldn't think of a better physician than Dr. Santana to treat me. So I had a very similar experience in that every time I tried to go out and run and play more aggressive sports like basketball or tennis, I would pull my calf muscle, kind of right where that calf and Achilles tendon join, the plantaris muscle as well as the gastroc muscle. And after trying conservative treatments and calf raises and exercises and wearing a brace all the time and then just getting frustrated that I must not be able to run anymore, I decided that this was very, very early in us starting this regenerative medicine business. And probably 4 or 5 years ago, had Dr. Santana come in the room after spinning my blood and creating the PRP. And after about two weeks, I started feeling a stronger kind of response and was back to doing my running within 2 months and haven't had a problem since. So 2 experiences, I think, that really pushed the needle for us and saying this is a big field. And,
this is real.
And we need to help more people. We need to get the word out. We need to let people know that they don't have to just give up the activities they love doing. They don't have to choose a big risky surgery that there's a much simpler procedure that may offer them a good shot at a recovery. I'll be the first to tell you we're not 1,000%. We don't heal everybody, but it's a significant percentage of our patients are able to get back to their activities they want to do and have a lot less pain without risky surgery or pain medications.
Yeah. I mean, I guess like right on the same line of foot and ankle injuries too. The other ones that we end up seeing is plantar fasciitis, right? So again, another common thing that we see from our patient that comes in complaints, and actually the data on plantar fasciitis in regenerative medicine is actually pretty good.
Yeah,
it works really well for addressing the plantar fascia. The downtime is very minimal. It's very well tolerated. It's an outpatient procedure. And it works really well. So another one of these conditions where there's really not much options, right? You try the stretching, you stretch your calf, you stretch your Achilles. If that doesn't work, you get a steroid injection, which may help for an amount of time, and then over time you have to get another injection, and then with all the side effects you get from steroids, from fat atrophy, where you kind of lose some of that fat underneath your foot. I think this is another option that we could do for that too.
Yep. Yeah, I agree. So, and it's kind of our big ones are the osteoarthritis. So, first toe osteoarthritis, ankle osteoarthritis, and then beyond that, Achilles tendon, plantar fascia, and ankle sprains, usually the ATFL tendon. See a lot of those injuries. We get a lot of great results from 16-year-old football players. Yeah. All the way up to people in their 80s and 90s. It's a wide spectrum of patients that could benefit from this. And if you have a family member or yourself that thinks you might be a candidate, please feel free to reach out to us. We'd be happy to take a look at intake information before scheduling appointments, just to make sure it's a good reasonable thing to spend your time looking into.
Yeah. You want to go to the
great idea? Yeah,
chat.
We got a couple of questions that came in.
All right, so this is a question from Blair. He says, "Is this type of procedure covered by Medicare?" I assume you're talking about the peripheral nerve stimulator for diabetic neuropathy. It is. So it's covered by Medicare and most insurers. There's a few hoops that we have to jump over. We have to make sure we have the right diagnosis. The other ones that we need to a psychological consultation, which we can arrange here in the office, essentially just to make sure that you understand this is a medical device that's going to be implanted in you. Straightforward questionnaire. Once we get those accomplished, then we can send the authorization to the insurance companies, and usually they would approve that. So, good question. Let's see. Harry's asking, what are the symptoms of diabetic neuropathy?
Yeah, so typical symptoms. Burning pain. That's I would say the most classical symptom. The other things that I hear a lot of are, I feel like I'm walking on rocks or walking on pebbles, walking on nails. It does escalate and subside, but most of the time it's just present all the time. It can be worse at night when you're laying down and not doing any activity. And it's a peripheral neuropathy. That means an outside the spinal cord nerve. And the tip of those nerves are usually the ones that are affected first. So it starts in the very tip of your toes, the very tip of your fingers, and then it moves towards the spine proximally. So we call it a stocking glove type distribution of pain, just like your sock or a glove on your hand, and it kind of moves upwards.
Yeah, it could be pretty benign. Some patients will just have more of a numbness sensation, which isn't too bad. But it can also be pretty severe. We have patients who just complain of severe pins and needles pain all the time there, and there's nothing you can do to relieve it. You can't change positions. You can't, you can't tolerate putting things on there, and it kind of represents like a complex regional pain sometimes, the way it presents.
Yep.
Okay, so a question from Harry says, "I'm hearing more about this type of medicine. Can you give us the spectrum of your clinic's wheelhouse?" Yeah. You want to take it?
I mean, we have a wide strike zone.
Yeah.
We have a big wheelhouse.
Yeah.
I would say our anything that is a painful condition that's preventing function. So we do a lot of orthopedic stuff for that: necks, backs, shoulders, knees, hips, you name it, the joint. Anything you would think of being scoped or operated on or replaced, we see a lot of those sorts of things for alternatives to those treatments.
Yep.
And then what we really touched on today is some of the nerve pain issues. So things that originate from a nerve, like diabetic peripheral neuropathy or nerve damage from a spine condition or this condition called complex regional pain syndrome. We can block those sorts of nerves. And then what our wheelhouse really is trying to block those with procedures, trying to manage conditions with one or a procedure maybe done in a series where it gives a long-term pain relief. We refer out people that require long-term medication management. That's not what our clinic's designed to handle or designed to manage. And there are some really good clinics in the area designed for that. And if that's what your condition is going to need, we can help refer you to the right clinic for that.
Or again, not just that, but also with surgeries. If it comes to a point where you come in for an evaluation and it's just one of these things that you really just need surgery for this procedure, where you have end-stage joint disease or end-stage spinal conditions or things where it's not treatable by what we do, then we're pretty straightforward and honest and let you know that you're probably going to need a surgical consultation. And we'll be able to assist you with that, at least give you another opinion on kind of the things that we do. So like Dr. Nagby says, our wheelhouse is pretty big. So anything related to joints and spines or pain. So we have we do treatments from a traditional point of view with regards to treating pain. We do injections and nerve blocks with steroids. We treat spines and joints, but we also do more advanced treatments. So we do minimally invasive procedures like the spinal cord stimulators, peripheral nerve stimulators, discectomies and stuff like that. And also we do regenerative medicine, which is stem cell therapy for joint and spine conditions, and PRP and prolotherapy and things like that. So depending on what we're going to use, kind of hinges on your evaluation and your consult. We take a look at what you have, what your goals are, what are your symptoms. We try and really get down to what the main source of your pain is and kind of treat those. It's never always straightforward. A lot of times we'll try something just to see if it's going to work or not. But for the most part, we've been doing this for a long time, so we have some experience to know which is going to work and which won't.
Yep.
Yeah. And then Barbara is asking, would this procedure work for sciatica problems? So everything that we talked about, regenerative medicine, we've treated that to treat sciatica problems, pinched nerves, radiculopathies. We've found really good success with that in treating spinal conditions because of that's causing it. From a stimulation point of view, whether it's a spinal cord stimulator or a peripheral nerve stimulator, yes, there are treatments for sciatica for that too, or any type of radiculopathy or peripheral nerve issue.
Yeah. Yeah, sciatica is probably number one or number two reason that people come to the office.
Scott's asking, are stem cell injections very similar to cortisol injections, but they are natural and last longer?
It's a good question. It's a big one. They're probably polar opposites. So they're similar in that it's something in a syringe, and we want to very carefully put that something in a syringe into a specific target. The similarities probably stop there. Cortisone is really a quote-unquote Band-Aid therapy. It's just masking the pain.
Yeah.
It's not stimulating any growth. It's not fixing any problems. I describe it as it's masking the pain to give you a window of opportunity to either heal on your own, to change your mechanics, do some physical therapy, really work on whatever the reason was that you developed the problem in the first place. And not have to suffer in pain while you're doing that.
Or allow you to go to that vacation you always wanted to go.
Yeah, it gives you a window to do something. Versus a regenerative procedure stimulates a healing response that eventually fixes the problem, but it doesn't happen like that. It takes a couple months for your body to really grow that tissue such that your pain goes down. So if your pain level's here, cortisone drops it quickly, but then usually eventually comes back. Whereas stem cells or regenerative medicine doesn't do anything right away, but then after a couple months, it slowly decreases the pain, and then if successful, fixes the problem so the pain stays down.
Yep. Yeah, that's that's exactly how I would use it too. So it's we still use cortisone injections here in the clinic. There is value utility to it. Like Dr. Nabby said, it's one of these things where it helps when you have pain to get rid of it and stop it. That's a really good indication for a cortisone or a steroid injection. But if the main goal is to get you back to functioning and for long-term improvements and lasting relief, that's where regenerative medicine comes in. Blair is asking, with the peripheral nerve stimulator, is there some sort of device where you control the amount of stimulation, and is the individual able to control this? So that's a good question, Blair. So with the peripheral nerve stimulator, we put that lead, the wire, into close to the nerve that we're trying to address. All of that is going to be underneath the skin, right by the nerve. The way you control it is there's a transmitter where you on a Velcro pad. Essentially, it looks like a little Velcro pad that you put over where the side of the lead is, and it's being controlled by a handheld device where you can turn it on, turn it up, you can turn it down. So you have full control of this all the time. One of the main advantages of the peripheral nerve stimulator is that if you are not having a painful day or you don't really need it, you don't have to wear that wearable brace to control it. And no one's going to know that you had that device in you or not. So it gives you that variability. If you like that sensation, if you need to block the pain all the time, then you have that piece of clothing on you, and that's going to help a lot there. Okay, so we'll probably closer to the last few questions. So I guess a good question. Here's a question from Barbara. If you're in the process of cortisone injections, could you do the stem cell injections at the same time?
So sort of. I like to wait for at least 2 weeks after a cortisone injection. Longer is probably better. Cortisone inhibits inflammation. That's how it works to block pain. And there's good inflammation and bad inflammation, and cortisone doesn't discriminate. It inhibits both of them. And the good inflammation is what stimulates growth and healing. So it's one of the reasons, for example, when you're having orthopedic surgery like a joint replacement, they're not going to want any steroids in around the time of your surgery. Same idea with the stem cell or a regenerative procedure, PRP. Cortisone, but then wait at least 2 weeks, preferably 4, before you do any kind of regenerative procedure.
Yeah, because so the healing response that your body does starts with inflammation. So if you have a steroid on board, it's going to minimize that inflammatory response, and therefore your outcomes are probably not going to be as good. So you want to give it the best chance you got. I'm with Dr. Nabby. I usually just tell my patients, if it's a steroid injection a month before we do a procedure, if it's an anti-inflammatory like a Motrin, or a Aleve, things like that, I would give it a couple of weeks before we would plan on something. Yep. All right.
Well, we thank everybody that tuned in tonight. We'll send out a link for the recorded version of this if you want to share it with any of your friends or family. And if you feel like you or someone you know can benefit from a consult with us, please, Michigan Center Regenerative Medicine, and our phone number is 248-216-1008, or you can find us on the internet, regenerativemedicinemichigan.com.
Yeah, and then we try to do these webinars at least once a month, so we have a whole library of these things that we talked about, from shoulder pain to back pain to hip pain to knee pain. So if you missed a topic, don't fret. It's in our website. You can go catch some reruns. It'll be syndicated soon.
The first versions are a little rough, but they're fun, and we appreciate you all that tune in to listen.
All right. Good. Have a good night.
Yeah, thanks, everybody.